It's my pleasure to call the next speaker, Professor Ihab Saad. He is a surgical oncologist at the Saudi German hospital, and he will talk about a very hot topic, especially in the last couple of years, HIPEC for locally advanced colorectal cancer.
Mr. Chairman, Assalamu alaikum wa rahmatullahi wa barakatuh. Mr. Chairman, Prof. Saleh, Prof. Yami. First of all, I'd like to thank the organizing committee for the generous invitation. It's a great honor and pleasure to be with you today. I'd like to take you in a rapid journey with HIPEC and colorectal cancer. First of all of us know that the colorectal cancer had a high incidence across the world. It represents across the world 1.8 million a year. Most of those cases presented with, from 10 to 30% of those patients presented with a locally advanced disease with a peritoneal recurrence. Usually this kind of presentation and this kind of disease kind of patient usually die from a local complications of peritoneal metastasis and not from the systemic disease. And that's why there was an urge to find a solution for such kind of presentation to help those patients. So how to manage exactly the peritoneal carcinomatosis with colorectal cancer? Actually, it's a very tough question, but we need to have a look first over what's stated in the guideline. According to the National Comprehensive Cancer Network guideline, if you have a peritoneal metastasis, synchronous peritoneal metastasis with a presentation of colorectal cancer, either if it's causing obstruction or not obstructing lesion. If it was obstructing lesion, they stated that they need to give this patient, they condemn this patient that only the palliative systemic therapy can benefit this patient due to that the disease is very grave disease and the overall survival will be poor. But even when treated such a condition with a marginal systemic therapy, the overall survival with peritoneal carcinomatosis is very low, up to 12 months. And another pooled analysis from retrospective study, the result of this study also, when treated the peritoneal carcinomatosis from colorectal cancer with the most modern systemic chemotherapy is still the median overall survival just 5 months. Going back to the guideline, if you have an obstructing lesion, you can palliate the patient in the form of colonic stenting, diverting stoma, or bypass. And at the end of the recommendation, they decided if you could do a peritoneal resection, in a limited peritoneal resection, you can do this in an experienced center, doing by an experienced surgeon, and the urge of the world that we need a randomized trial in this category. Until to date, we have 4 randomized trials addressing the cytoreductive surgery with HIPEC or without HIPEC. The most famous was Eric Verwal trial. It was published in 2003. He randomized the patient with peritoneal carcinomatosis either to have a cytoreductive surgery with HIPEC followed by 5-fluorouracil, which is systemic chemotherapy, or to have a systemic chemotherapy, and the result was very impressive at that time. 43% of the HIPEC group have an overall survival for 2 years, while 16% in non-HIPEC group. In fact, Eric Verwal trial have faced a lot of critics. One of its critics, he didn't compare exactly the HIPEC component. He put a HIPEC with a cytoreductive surgery against a systemic chemotherapy. Also, the long-term survival and long-term follow-up of that trial, both are more comparable after 8 years of survival. The second issue, he didn't use the modern chemotherapy like oxaliplatin. Also, there was a lot of patients with appendiceal origin enrolled in the study group. The other randomized trial, which is a famous PROG7 trial, it was published in 2018. They randomized the patient with peritoneal carcinomatosis. All of them have a cytoreductive surgery. Then the randomization either to have a systemic, have a HIPEC with oxaliplatin or a systemic chemotherapy, oxaliplatin for 30 minutes. Unfortunately, the result of PROG7 was not, as expected. The overall survival in a HIPEC group was 41 months, in non-HIPEC group 41 plus 2 months, and also the recurrence-free survival was not significant. The result, they concluded from following PROG7 that every patient with peritoneal carcinomatosis should offer a surgery, at least cytoreductive surgery, because the cytoreductive surgery by itself, it increased the overall survival of the patient with peritoneal carcinomatosis from 18 months up to 41 months, which is good. Also, the adding of oxaliplatin and the HIPEC was not adding a beneficial result to the patient with peritoneal carcinomatosis. But in the subcategory of the patient with peritoneal carcinomatosis index from 11 to 15, those subcategory of the patient benefit and the overall survival was better than the control group. Still, on the other hand, the French guidelines is strongly recommended to offer cytoreductive surgery and the HIPEC for all patients with peritoneal carcinomatosis. This is based on two famous studies, one a retrospective and the other prospective study. Both of them showed an improvement in survival with the CRS and the HIPEC up to 62 months in one study and 35 months in another study. But still the other part of the world is still against this idea. If you looked at the ASCO recommendation 2022 and Chicago's consensus 2022, they still recommend against HIPEC as a modality of treatment, but they offer cytoreductive surgery or encourage cytoreductive surgery for a limited kind of the disease. So until this moment, unfortunately, we don't have a consensus about how to manage peritoneal carcinomatosis from colorectal cancer. What about searching for an adjuvant treatment? What about prophylactic or preventing this condition from happening from the start? And to do this, there is a trial in the world, or there's a trial for adjuvant HIPEC. The most famous is a French trial called Prof, Dutch trial COLPEC, and our pilot study that we have already done in our institute. The whole trial of adjuvant therapy depends on the defining and identifying the high-risk population to develop a peritoneal carcinomatosis, and if you are going to give them some kind of prophylaxis or not. And the high-risk population defined in this 6 item either to have a minimal serosal involvement or ovarian metastasis at the time of resection or perforated tumor or mucinous ring. Prof, it was a phase 3 randomized trials. It aimed at evaluation of the potential and potential benefit of the second leg surgery for a patient with a high risk of peritoneal recurrence, and they defined the high risk those patients with a minimal peritoneal carcinomatosis, ovarian metastasis, perforated tumor. All of them received an adjuvant chemotherapy, then under follow-up for 6 months. If there was no sign of recurrence, they randomized the patient either for surveillance or surgery plus HIPEC. Unfortunately, the result was not definitive as well. There was no difference between both group in overall survival and the disease-free survival. And they addressed this question in the study that was published in the World Journal of Gastroenterology. Adjuvant HIPEC, does it really save life? And they concluded it doesn't add any benefit for the patient, and we need to stick to the standard surveillance for the patient and identify the patient with high risk to developing peritoneal carcinomatosis. The other trial, which is COLPEC trial, it addressed adjuvant HIPEC as well for those people who present with high-risk feature, and they defined the high-risk feature to be T4 or perforated colonic cancer, but it was a little bit different than Prof. They started adjuvant HIPEC and early adjuvant HIPEC either immediately during operation or within 10 days or maximum 5 to 8 weeks. Unfortunately, again, the result was not definitive, and the overall survival and the disease-free survival was not significant between the study group and the control group. They concluded that T4 cancer or perforated cancer treatment with adjuvant HIPEC with oxaliplatin did improve the peritoneal metastasis-free survival, and the routine use of adjuvant HIPEC in a high-risk population, T4 or perforated tumor, it's not recommended based on this study. And this is our pilot study in our institute. It's again addressing the high-risk patient, how we are going to prevent peritoneal occurrence in this kind of the population. And the aim of the study to study exactly the effect of we are going to identify the risk of those who is going to develop peritoneal carcinomatosis, how we are going to help them. Is HIPEC and early HIPEC going to help them or not? And this we excluded from our pilot study people with or patients who have a metastatic disease or a comorbidity. Then the randomization done intraoperatively either to go for the study group or the standard treatment. Standard treatment with cytoreduction, getting the disease out. Then the patient will receive a chemotherapy for 6 months, or having the disease out with CRS and immediate intraoperative chemotherapies in the follow-up up to 18 months. This is a demographic feature for the patient in our study. We try to compare the radiological sign and feature of the patient at high risk to develop peritoneal carcinomatosis with the intraoperative finding, and this was the figure of people who have a colonic thickening, evidence, radiologically evidence of ovarian metastasis, and intraoperatively it was compared with the radiological result. To have a complete cytoreductive surgery, we had to do an additional procedure intraoperatively. It was done in 16 out of 21 patients, like a partial cystectomy, small bowel resection, sleeve gastrectomy, and we have 11 out of 16 patients, female patients, we had to do bilateral salpingo-oophorectomy and hysterectomy. There was no mortality in our trial, only one morbidity, which was intraoperative, postoperative infections that was managed conservatively, and the patient discharged within the following 2 or 3 days from readmission. The median length of stay in the control group and the study group was comparable. The pathological assessment showed that 10 specimens are classified T3 lesion, while remaining 11 specimens classified T4 and T4A and T4B. The 8 remaining specimens have non-nodal disease, while other 8 specimens have staged as N1 disease, while the remaining 5 specimens were staged as N2 disease. All of our patients in our study received systemic chemotherapy except for 4 patients. 2 of them have a progressive disease, and the other 2 of them have interrupted systemic chemotherapy because of toxicity of the disease. For the result of our study, we have the median progression of peritoneal recurrence-free survival up to 17 months in the study group and 12 months in the control group. There were 2 specific variables which strongly affect the peritoneal recurrence, which is a tumor marker and the nodal involvement. Actually, and unfortunately, the nodal involvement in the study group was much higher than in the control group, and this might affect the result of our study. So in our study, we were able to give those patients with the cytoreductive surgery and the HIPEC 17 months with a median survival compared to 12 months for the systemic chemotherapy. Actually, unfortunately, the presence of the heavy nodal infiltration within the study group, we presumed or assumed that it might also lower our result in the study group, but we cannot. This variable is not amenable to be standardization along the treatment because we cannot detect this variable except after the pathology assessment. So if we took the 3 study or the 3 trials together, Profiloshape against Colbec against NCI, Profiloshape and Colbec didn't show a definitive result. In NCI, it's just a pilot study. There is no significant p-value, but still it can give a hope for those people. For the Profiloshape and Colbec, they used mitomycin for just 30 minutes, which was a big question mark in all of the French trial. We used mitomycin, they used oxaliplatin, and we used mitomycin. Oxaliplatin is stated as to be end of the road by Wim Salin. Also, the timing of the HIPEC. The timing of the HIPEC in Profiloshape and in Colbec trial, the assumption of having these exfoliated peritoneal cells with the first surgery to be spread everywhere in the peritoneal cavity give the immediate timing of the HIPEC advantage rather than delayed HIPEC. That's exactly what we did in our trial. In Profiloshape and Colbec, it was a delayed, either 6 months for Profiloshape or at least 10 days in Colbec trial. Also, to have a delayed HIPEC might delay the adjuvant systemic therapy. The adjuvant is very important for those people. Also, the inconsistent patient selection in Profiloshape and Colbec, the high-risk patient was exactly identified and highlighted. That's why we try to include all high-risk features in our trial. The take-home message after this short journey about the history of HIPEC in the world, until this moment, we don't have a consensus about the importance of HIPEC for those people with peritoneal recurrence, but the message that we wanted to deliver, don't stop trying. These are a very aggressive treatment. Systemic chemotherapy doesn't help. We need to look for a local treatment, but we need to assign another randomized trial with a specific and more accurate patient randomization and recruitment. Finally, I'll end with Prof. Sugar-Picker statement in 2017, peritoneal metastasis when optimally treated can be cured in selected patients. Peritoneal metastasis can be prevented. Thank you so much.